In today's episode, we're going over a case study of a lateral ankle sprain in a trail runner. Let's go. So I have a freebie for you today. It is an evidence-based guide to lateral ankle sprains, a cheat sheet. We go over a lot of really good stuff that's going to help you out with today's lesson, like the prevalence, the history, the prognosis, predisposing factors, mechanisms of injury, anatomy, diagnosis, differential diagnosis, treatment, return to work and sport, and injury prevention for lateral ankle sprain injuries. It is packed with info, guys. 100% free. Going to put a link in the show notes. Definitely check that out. Let's get moving. So who's the subject for today? Well, it's a 29-year-old female. She is a recreational runner. So basically she runs somewhere between 2 and 4 times per week. And she actually likes really, really long distances. So somewhere between 60 and 120 minutes. Yep. So she's one of those kind of ultra distance runners, although she doesn't really compete in ultra distance races. The other piece that she really likes trail running. So oftentimes she's running in wooded environments that are sandy, so a little unstable for the ankle. And this is an important consideration from a rehab standpoint. She also does a little bit of recreational strength training 2 times per week in a total body fashion. The only thing is that she's really not a strength training person. She doesn't really like lifting weights. We'll get into this a little bit later, but the reason why she does it is because she's had an ACL reconstruction surgery and she's trying to kind of continue rehabbing that and keeping that healthy over the course of time. Although she's not that person that loves to be in the gym, she likes to do fitness outside of the gym. On top of that, she's a recreational rock climber. She does that 2 to 3 times per week. This is obviously going to be something that's important because we are falling off the wall, right? And we land in an odd position. We have to make sure the ankle is prepared for that. Speaking of rock climbing, this is exactly how this athlete got hurt. She came to me 2 weeks after her injury. Basically, she fell off the wall while she was bouldering and inverted her ankle. So basically landed on the side of her ankle, very painful. She ended up going to the emergency room because this thing blew up. Fortunately, we had negative x-rays and the physician ended up recommending physical therapy, which is great. I think that was a great way to handle the situation. When she came into me, it hurts a lot to walk. And basically, she can't really do anything that she loves to do. So she can't really lift, run, or climb. We'll talk about this a bit later, but she was also very fearful. So one of the major reasons why she wasn't able to do these things was simply because she hasn't challenged herself and she didn't know what was okay and what wasn't okay, right? Which is a big problem with lateral ankle sprains because largely they're very scary. They resolve quickly. People aren't really sure what's okay and what not to do. And then the last piece is they tend to have a really high recurrence rate. So unless you do a good job with your physical therapy, these folks end up kind of minimizing their problem and end up with long-term issues because they never addressed it in the first place, okay? From a career perspective, she has a desk job. So that's nice in the initial stages of rehab because she doesn't have to do a bunch of manual labor or something requires her to be on her feet all day long. She's able to sit a little bit, which was nice. We'll talk about that a little bit later. And she's also very disciplined. And she's a big fan of fitness in general. Like I said, she likes outdoor fitness, though. She likes to run. She likes to hike. She likes rock climbing. Sometimes this ends up being a bit of an issue because folks don't want to go into the gym to do the movements that are more important from a rehab perspective. Although she did a pretty good job in general because she's so disciplined and really wants to get back to her fitness. I'd like to talk a little bit about training age because I think it's relevant for rehabilitation. If someone has been weight training for years and years and years, it's pretty easy just to give them a few rehab exercises and you can usually take it and run with it. You know they're going to have decent technique as a result. Generally speaking, she's been fit for the majority of her adult life. It's just that she was never really an indoor weightlifting, powerlifting type athlete. She doesn't love weight training, although she has been fit and athletic for the majority of her adult life, like I said. So the patient's goals are largely to reduce her pain, restore her strength and range of motion. And to be honest, she's actually quite fear avoidant at this point. She fell on her ankle, it ballooned up, it got enormous. She can't walk, it feels terrible, right? She can walk, more on this later, but can't walk well. She has no idea how to progress back to running or strength training, right? She's not sure how to handle it, didn't get a lot of guidance from her physician. So she's just kind of at a point where she's like, I don't know what the heck to do. What's okay? What's not okay? Can you kind of guide me through this, right? And largely, I have my own goals. So as a physical therapist, I'm constantly asking my patient what's important to them, what are their expectations, what are your goals? Let's make sure we meet those. But the other part is I'm constantly thinking about my own personal goals for the patient. And I tell them, right? I say, hey, you know what? I want to make sure that we guide you on your path back to success, but there's also a fairly high recurrence rate of these. I want to make sure that we reduce the likelihood that you have a future injury. So I kind of develop my own goals for the patient. They develop their goals, and we kind of meet together and just kind of have this nice laid out plan so the expectations are kind of met from the rehab process. Okay. And the other piece is that I had actually worked with this patient before for a lot of her ACL reconstruction rehabilitation. She just had a heck of a time getting back her quad strength, and she had a heck of a time with pain. And anytime she kind of backs off her exercises, she notices her knee gets more painful. She gets weak on that side, and she wants to make sure she doesn't take a step back rehabbing the ankle, right, from a knee perspective. So guys, if you like what you're learning about so far, then I want you to go and check out the Fitness Pain-Free Mini Course. So I made a mini course. It's absolutely free. That's the next logical step if you want to learn more from me. So in the course, we go over 5 lessons. That first lesson is how traditional schooling has failed us, right? So schooling is phenomenal from a physical therapy perspective, but doesn't really teach you how to work with high-level athletes in the fitness world, right? Doesn't always teach you how to do the lifts appropriately. Doesn't teach you about progressions and regressions of common lifts within the gym. Doesn't teach you how to program normally, how to write rehab programs, or how to write injury prevention programs for these folks. Next thing we go over, 7 reasons why people get hurt in the gym, 4 simple steps to getting your clients out of pain, how to build the career of your dreams and earn the respect of your community. It's all well and good if you know exactly how to work with folks within the gym. But if you can't get these folks through the door on a regular basis, then you're simply not going to be living the dream that you want to, because you can't get the patients through the door that you want to work with. Okay. So I'll show you how to do that. And lastly, we'll talk a little bit about the Fitness Pain-Free certification, right? So I'll leave a link in the show notes. I definitely recommend checking this out. Once you sign up for the Fitness Pain-Free Mini Course, you will be automatically placed in the waitlist for the Fitness Pain-Free certification. Now, the Fitness Pain-Free certification is the course, the certification that I wish I had as a new grad that fills in all the gaps in knowledge that you don't get in physical therapy school. So A, you'll gain complete confidence working with injuries in the strength and fitness world. You'll learn optimal technique for both health and performance from myself and some of the best coaches in the world. You'll master programming for rehabilitation and injury prevention. Have fun while earning a whole bunch of physical therapy and physical therapy assistant credits. You have 31.5 of those. You'll also gain NSCA credits as well as CrossFit credits if you need those. This is the equivalent of a university education in working with injuries in the weight room. I really believe that. I've been adding to this thing over the past 5 or 6 years. It's massive, a ton of phenomenal information. And lastly, the biggest goal is just to fill your day with the patients you love working with and building the respect and admiration of the communities you love working with. So I'll leave a link in the show notes. Sign up for the Fitness Pain-Free Mini Course. The certification is open 4 times per year for 1 week to enroll into. If you're on the wait list by signing up for the Fitness Pain-Free Mini Course, I'll alert you when that next enrollment period is open and you can get started. Let's get back to the show now. So moving on to the objective portion of the evaluation, we took a look at her strength and we utilized manual muscle testing. If I wanted to be super comprehensive, I could have used an isometric handheld dynamometer. I didn't at the time. Reflecting, we can always make progress, by thinking about the things we should have done and maybe more of that, doing more of that in the future. I think oftentimes using a handheld dynamometer just takes so much time that sometimes it's really not worth it. In this case, I just used my hands to test her strength. And she basically had pain with resisted eversion. And she also had pain when we did a calf raise. Okay. From a range of motion perspective, we used a half kneeling ankle dorsiflexion mobility test. I will have a link in the show notes if you want to see how to assess that. And she was about 2 inches from the wall on the effective side. On the unaffected side, she was about 4 inches from the wall. So she was about 50% restricted there. It was also painful. And the thing was, most of her pain was laterally, and that makes sense. So if you roll your ankle, invert your ankle, you're going to be stretching the ligaments on the outside of the ankle, maybe causing some injury to the bones or cartilage on the inside of the ankle. So that's where the majority of the pain usually is. So it started to rule in lateral ankle sprain from the get-go based on her subjective information, but also the initial information we were getting from an objective perspective. She was also limited in eversion as well as inversion, about 25% difference from left to right. And then plantar flexion was symmetrical. Now, I believe that ankle sprains are pretty interesting because largely you're stretching ligaments when you have this injury. And you would think like, okay, this person's going to be more lax because of this injury. Now, this is oftentimes the case for some folks, For some folks, it becomes the opposite. They tend to stiffen up over the course of time. This is probably because your body's laying down some scar tissue and is attempting to stiffen up the area again. So if you stretch all the ligaments within your ankle, your body says, hey, let's get these things a little tighter again. Let's restrict that range of motion. It does that by laying down scar tissue. And a few other things are going to be relevant. We'll talk about that in a bit. So from a regional interdependent standpoint, we always take my patients through Champion Performance Specialist. It's kind of a top tier test like the Selective Functional Movement Assessment. We've developed it at Champion PT and Performance just to see how they move generally. And from a single-legged squat, kind of heel tap perspective, I was noticing more of a hip strategy. So largely, she likes to move more through her hip, a little less through the knee, a little less through the ankle, probably because the ankle hurts, but she also has a history of ACL reconstruction. So maybe some of that quad weakness or some of the knee pain was lending to that, right? We'll talk about why looking at the hip might be important for lateral ankle sprains in a minute, but that's just one of the things I was picking up from an objective standpoint in the eval. If you are objectively loving the podcast so far, please hit that like button, leave a comment, and subscribe. Helps this channel out tremendously. What other objective findings do we have? Well, one of the big ones with a lateral ankle sprain is a lot of swelling, and she had a lot of it. I would say her swelling was moderate to severe. You can take some circumferential measurements to see exactly what it is during your evaluation, just to see if you're progressing over the course of time. We did not. Needless to say, this thing was very, very swollen, very bruised. From an imaging perspective, we were lucky. She came in with negative imaging, which is great. So probably not dealing with any fractures at the moment. We did, however, go over the Ottawa ankle roll. So basically looking to see if there's tenderness to palpation of the medial malleolus, lateral malleolus, navicular, fifth metatarsal head, and the ability to ambulate for 4 steps. And she could do all those things. And she had negative imaging. So I'm pretty certain she didn't have a fracture. All right. From a palpation perspective, she had tenderness over the peroneals as well as ATFL. If you think about the mechanism of injury for an inversion sprain, you're rolling your ankle, stretching the ATFL, potentially stretching out the peroneals as well. She has an irritation there, so I think that the peroneals may have been involved. From a special test perspective, she had a positive Taylor tilt test, which may indicate there's an injury to either the ATFL or the CFL ligament. From a balance perspective, she was hardly able to balance whatsoever. As soon as she takes up her opposite side leg, she basically falls right over. I say she could balance for maybe 2 or 3 seconds very poorly. Okay, so her balance was not very good whatsoever. Now, if you have someone who's a little bit more functional after a lateral ankle sprain, maybe you see how many times they lose their balance during a 60-second single-legged balance test. You can do the same thing with the eyes closed. You can also potentially try a wide balance or star excursion test. She was so limited with balance initially that we just didn't have to do that, okay? We're also on the lookout for concomitant pathology. So it did seem like she had an inversion sprain injury, but we're looking for a high ankle sprain as well. Sometimes folks think they have an inversion ankle sprain, but really they end up twisting their ankle and just didn't realize it. It certainly happened to me. But she did have a negative squeeze test. She had a negative dorsiflexion external rotation test, and that kind of rules out a high ankle sprain. If you guys want to learn more about diagnosis of lateral ankle sprains versus high ankle sprains versus a medial ankle sprain, I'll leave a link in the show notes. I have a really good video about diagnosing that, okay? And largely, I ended up diagnosing her with a lateral ankle sprain, and I figured it was about a grade 2. Now, the grading system is very subjective. So 1 would be minor, 3 would be severe. I feel like she was probably close to that 2 or 3 range. She was able to ambulate at this point. So grade 3, generally those folks can't walk, but she's also 2 weeks out from the injury. So she potentially did have a grade 3. I would say she was probably somewhere between a grade 2 and a grade 3. Again, these are all subjective gradings. So it's not like I can say for certain that she was either one, but that's what we evaluated her as. But that's how I diagnosed it. All right, so did the diagnosis. Now, what's the plan? So generally speaking, for lateral ankle sprains, we want to do some sort of conservative management involving physical therapy, okay? Back in the day, after lateral ankle sprains, surgeons were much faster to prescribe surgery for lateral ankle sprains, especially those grade 2, grade 3s, right? Over the course of time, we kind of found that these do pretty dang well and comparable to surgery if we just manage this conservatively with physical therapy. So that's our decision, right? And generally speaking, the majority of folks that have lateral ankle sprains, they usually start feeling quite a bit better around the 2-week mark, okay? The only problem with this is that these folks that have a lateral ankle sprain also end up having recurrences. So around 50% of folks that have a lateral ankle sprain will have either a recurrence over the course of time, or they'll have chronic issues like swelling, pain, lack of ability to get back to their activities, right? So despite this getting better fairly rapidly, generally speaking, folks have high recurrence rates, and then long term, they don't have the best outcome. So I recommend folks do somewhere between 6 and 8 weeks of physical therapy, even if those symptoms really start resolving quickly. Okay. The other part is that if folks just can't get to the point where they feel good, let's say months later, they keep on having recurrences, they keep on having swelling, pain, can't get back to their activities, they've tried all the physical therapy in the world, then we start to think about referral to the surgeon. And if someone has, let's say, some sort of concomitant pathology they weren't aware of, like osteochondral damage, or if someone has a complete rupture of the ATFL or other ligaments, you can have surgery to try to correct some of this, namely an ATFL reconstruction surgery. But I just didn't think that was a good first step for this patient. Obviously, we started with physical therapy. So one of the first steps in the treatment process is going to be some form of education. From a cultural perspective, for whatever reason, when folks have lateral ankle sprains, the common wisdom is to rice it. Okay. So this image I have on the right side of the screen, I apologize if you're listening to this podcast. If you're on YouTube, you're watching the video form of this podcast, you'll be able to see it. But the front page of Google, when you just look up lateral ankle sprain, what is the fastest way to heal a sprained ankle? It says very plainly, rest, ice, compress, and elevate. This is coming from the Mayo Clinic. All right. So usually a source that we can say, yeah, that's good information. And I think parts of the RICE formula, rest, ice, compression, elevation, are good on the early stages after someone has a lateral ankle sprain. But largely, there's no research to support this formula, right? Basically speaking, RICE is more or less wrong. And the ankle joint loves motion after you have a lateral ankle sprain. And this is important to tell your patients because oftentimes they'll read this online or their physician will tell them this. And that's simply not the case, right? So we're going to move this as much as we're able to tolerate. Later on, I'll tell you about which exercise we like to use. And then in terms of, let's say, exercise in the gym or running or any other activity that patients like to do in their free time, we want to try to keep doing this as much as we possibly can, okay? We'll talk about modifications when we need to, but largely we want to keep people exercising. We don't want to stop people from working. We want to keep them going as much as humanly possible early on, okay? So this was important for my patient because she thought that she couldn't do anything. And this was largely coming from her physician, also what she's read. And on top of that, she was so afraid of the injury that she had, just kind of paralyzed by that fear, excuse me. The other thing to educate your patients about is that these things have a tendency to get stiff, right? So if we're not actively working on mobility, they can get too stiff over the course of time. We can lose range of motion. And obviously, that's not good. When I'm doing an evaluation with a patient and they might not have had a lateral ankle sprain, let's say it's any sort of evaluation, and I notice they have stiffness on one-sided ankle, my next question is almost always, have you ever sprained your ankle? And usually the answer is yes. And one of the major reasons why folks have limited mobility in their ankle over the course of time is because they sprained it at one point and never got that range of motion back. Okay. The other thing I like to educate my patients on is basically, hey, you got a lateral ankle sprain. These things feel terrible. They're very scary. What's interesting about them is they tend to make a turnaround very, very quickly. So most folks, the majority of your symptoms are gone by around 2 weeks. Now, this was not the case for my patient because she was here at week 2 and she was still having quite a bit of pain and swelling. However, the problem is that even in the bad ones, the symptoms tend to go away relatively quickly. Most folks tend not to do any form of rehabilitation. And then later on, there's a high recurrence rate, as high as 50%. A lot of folks end up developing chronic ankle instability, future sprains, things get worse. They have more pain, swelling, disability, and this can be a long-term issue. And what's great is that if you actually intervene with a good physical therapy program, you reduce recurrence rates, you reduce the likelihood of chronic ankle instability. So even though these things tend to feel better relatively quickly, we still take them seriously. So step 2 from a treatment perspective is to calm the area down. Now, the way we tend to calm the area down after lateral ankle sprain injury is first to remove anything that's keeping people really swollen, really painful, limping, moving them in a negative way, right? So for our patient, she stopped everything, right? So she's on the opposite end of the spectrum. I actually want to get her moving more because if she does a little bit of easy exercise, easy walking, moves more throughout the course of the day, we know that's going to help her. It's going to help get rid of some of that swelling, get the muscles working a little bit more so, right? But I've certainly had patients, they're in the middle of a sports season, roll their ankle, they go right back to playing afterwards. And I think this is one of the major reasons why folks have a high recurrence rate, because this area is not ready for the level of activity you're throwing at it. You're doing it anyway, just because the sport is more important for whatever reason. I understand if you're in the middle of a sports season, sometimes like you have to suck it up, I guess, right? But the problem with that is that you're going to lead yourself to longer term problems if you don't address this early on. Okay. So at least for the patient today, I just had to educate her on moving more frequently and let her know that motion is good, right? Because if we move a little bit more, improves our return to sport times, makes us feel a little bit better, improves range of motion, reduces swelling, all that good stuff. So you actually calm the area down by moving more. And then we basically just have to apply a physical therapy program, which is going to consist of some sort of strengthening to the foot and ankle, starting with easy exercises and working our way to harder exercise over the course of time. Restore dynamic postural control, which is a fancy way of saying you have to restore your balance. We'd like to have a slow progression back to running, which I'll show you how we do it, but generally starts with a slow introduction of impact and then gradually working ourselves to a return to run program that starts with low volume, low intensity, and just progresses back up to higher volumes like our patient wants to get back to. We also think about modification of the training program for the long term. Since this patient likes trail running, and because of that, she might be more at risk for having an ankle sprain. She's going to be running on a lot of uneven surfaces in the future. We know that she's at an increased risk of having another ankle sprain because she had a prior one. And maybe it's important to keep some foot and ankle strengthening and some balance work in her program longer term. Doesn't have to be a lot, but a little bit goes a long way. And I'll talk about how we did this in the future. And then if not successful, if she's not making progress whatsoever, we just refer out to a good surgeon that you really trust. And then we can kind of figure things out, get more imaging, figure out the next steps, potentially look at surgery. But largely, we're going to see how physical therapy goes first. So now that I've gone through a case study and you see exactly how I like to treat lateral ankle sprains, you need to see the exact exercises I like to use to get these folks out of pain and back to their activities. I have a really good video for you. I'm going to leave a link in the corner. It's my favorite single leg balance exercises for folks after lateral ankle sprain injuries. Definitely go check it out. And lastly, I just want to say thank you so much for your support. If you're watching this on YouTube, please hit that thumbs up button. I'd love to hear your comments on how I like to rehab. Did I miss something major? Let me know. Disagree with me? Let me know, right? I love to hear it. And it also helps me out tremendously if you subscribe, right? Because you can see more videos like this, keep up to date with all the good stuff I'm putting out there. If you're watching the podcast version of this, please give me a 5-star review. A positive rating helps me out tremendously, allows me to continue making content like this in the future, 100% free for you. And if you want to go the extra step to really support the channel, consider subscribing to Fitness Pain-Free Insiders. It's a comprehensive educational resource and toolkit for the fitness and rehab professional. Think Netflix, but for trainers and physical therapists. It's premium content from yours truly, very similar to the podcast here. I've been updating this monthly for the past 5 years or so. I'm currently working on adding lots of courses, right? So not only are you getting more lessons, webinars, guides, you're getting complete courses in here. I've also recently added CEUs. So if you're a physical therapist or physical therapy assistant, you can get CEUs. And the best thing is it's only $1 to get started. After that, it's $25 per month, but you can cancel at any time, right? Get CEUs, $1, cheapest CEUs you can possibly get. All right. So if you want to learn more, I'm going to leave a link in the show notes. But otherwise, when you get started right away, go to fitnesspainfree.com, click on the programs link, click on Fitness Pain-Free Insiders online library to get started. If you want to see the references, there are a million of them, and I know you can't see them very well now, but I've left all the references in the show notes section. Check those out if you want to see the studies I included. Thank you guys, and goodbye.